So, I mean, as a nurse practitioner that,
Mm-hmm.
went through the whole program, I'm really curious. What kind of education in wound care did you get?
I've been a nurse practitioner for 8 years, and I was thinking, when did I learn wound care?
Mm-hmm.
Yeah.
What came to my mind, I believe it was one chapter in one class and maybe a few questions on the exam.
Hello, everyone. Welcome to Healing by Design, the podcast where we amplify the voices that matter most in wound care. I'm Jen Bierhup, and I am here with my co-host, Therese Laub. We are so glad you found us, and we can't wait to dig into today's conversation. Before we jump in, I do want to take just a quick moment to cover a few things. Everything we talk about on this podcast is meant to educate and inform. It's not medical advice, and it shouldn't be taken as a diagnosis or treatment recommendations. Your situation is unique, and your healthcare provider is always your best resource for decisions about your care. The opinions our guests share are their own. They don't speak for PAWSIC or our sponsors. And if any of our guests have professional or financial ties to products or companies we discuss, we'll always be upfront about that. One more thing. If you're ever dealing with a wound care emergency, please don't look to us for that. Go to a provider right away. Now that we have all of the disclaimers out of the way, let's dive right into our show.
For joining us. Our next guest has spent over a decade proving that clinical care and great operations are really the same thing done well. Alicia Bobak, a family nurse practitioner and wound care certified clinician, and right now she's Senior Vice President of Operations for a multi-state physical medicine and rehab organization, wound care and palliative care teams across Illinois, Wisconsin, and Alabama, building the systems that let great care scale. And at the heart, she's a mentor, someone who's just as focused on growing the next generation of clinicians as she is on building what they'll work in. Please welcome to Healing by Design, Alicia Bobak.
Thank you guys so much. I am incredibly honored to be a part of this podcast and to be a mentor to CNAs, nurses, nurse practitioners, clinicians for the wound care space because I look to you two as mentors. And I would not be where I am today without mentorship. So I'm very excited to get into the nitty gritty of wound care education and why people may not be looking for it or know where to look for it and really guide them to help finding that and touch upon some issues that we see in wound care every day so we can help improve our education, which in turn helps the patient and patient outcomes. So thank you.
Awesome. We're so excited to have you. So, Therese and I actually spent a long time yesterday kind of talking about this topic because we could probably spend like an entire day on this topic.
Yeah.
So we were like, what is the goal? Like, what are we hoping to get? Like, what's the actual end goal of what we're hoping to get out of this talk today? And I think it's just, and Therese, remind me, what was our goal that we wanted to get accomplished today? It was the overall like.
Well, we're talking about education, right? And how there's so much of it, and that we want to empower the people that are listening to, take it upon themselves to look at what's out there, to understand how education can help them advance and help them understand their patient load better. That was, I mean, I think that was probably is kind of a call to action for the people in the audience to really understand how to look at the education that's out there and to really find the education that fits in with what they're doing, right? And how it can help them in their field of work and what they're doing with their patient care.
I think the most frustrating thing that we see is there too much wound care education out there? Is it like such a deluge that you don't know what you're supposed to pay attention to?
Nothing's standardized for anywhere across the board. That's, I think, key. We need to speak to the mountaintops, to the key stakeholders about standardizing wound care education across all healthcare organizations, post-acute, acute.
Yes.
Yeah, and that falls into the standardization of wound care, right? Because education falls right into that. And I think that's one of the things we're lacking in this industry is that there's not a standardized way of doing it in all spaces.
I mean, we have this conversation every day in some way, shape, or form with everybody we talk to, Alicia. But it's really difficult for us to hold people accountable and to hold them accountable to a certain level of education if there's really actually no real standard of care.
Right.
Like anybody and their brother can hang I'm a wound care person out on their shingle,
Right.
and they've never actually spent time educating themselves.
Or doing wound care, actually doing it.
Right.
Yeah.
That's what's
Or
the
even seeing
frustrating part.
wounds. You know,
Yeah.
they just have templates out
Mhm.
there.
Yep.
Stage 2, here's the template without
Oh,
even
yeah.
looking at the wound.
Yeah.
And I think
Yeah.
with AI, that makes it even more difficult because people
It's
can look
more
things
difficult.
up and they think that they know because it's all
Yeah.
laid out in this form that looks really pretty.
Mhm.
But it's like, it's not the experience behind it to recognize when things go wrong where that might lead.
I didn't even think about the templates. Oh, good.
And I think AI, AI is a great tool, but I don't
Mhm.
think it's
Mhm.
quite there yet as far as
Mhm.
wound care because like Therese said,
Mhm.
you can put in give me an intervention for stage 2 pressure injury. And they're
Mhm.
giving you a blanket template, right?
Right.
Mhm.
A
Mhm.
blanket intervention.
Mhm.
But they're not asking the questions about the patient
Mhm.
and their underlying disease
Mhm.
processes. How is their home environment?
Mhm.
Hopefully in the next couple of years, AI will prompt those questions, right? To develop a proper intervention, but we're not there yet. We're not.
Yeah. No. I mean, I think the problem with it is that we all know, and one of the biggest things, Alicia, which is why we were so excited about having you on, is that you've been in Personic. You've been like the boots on the ground teaching the nurses and teaching the NPs, especially during the heyday of the CTP situation. You were out there. You were seeing this. You were seeing this lack of education problem firsthand every
Mhm.
single day.
I still do,
And I,
unfortunately, in the sniff space.
oh, yeah.
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 What do you think is the biggest problem in the sniff space when it comes to that?
I think education on the wound care nurses, time,
Mhm.
right? They're just trying to get through all of the patients
Mhm.
in one day because they have to document. Documentation's holding us down. But I do think that wound care, often nurses and clinicians, well, the wound nurse will handle it. The
Mhm.
wound nurses got it, but they never put eyes on the wound, like the primary. I'm all for primary clinicians getting trained on wound care, and I'll stand by that. That's where I found it as a barrier in my knowledge when I was a new grad. I
Mhm.
needed to learn about wounds because that was the primary thing I was seeing in the home setting. That's what I was rounding in. But
Mhm.
in the skilled nursing space, yes, you have your nurses doing assessments. They're there. There's someone always there to support, turn, etc. But if the clinicians or physicians are just putting in their notes, wound care team on consult, wound care following, well, that clinician is still liable. They are the ones giving
Mhm.
the orders.
Yep.
So they need to have at
Mhm.
least a basic understanding of wounds.
And that means like everybody. That's not just like one or two people. That's
That's
like
the
Correct.
team.
that's the
It's the
team
whole
that
team that's
needs.
involved.
The
Yeah.
whole team, you would be shocked, you know, me being having that wound care experience and me going to these
Mhm.
skilled nursing facilities rounding, I see some of these reps on the legs and
Mhm.
I just want to curl up in a ball.
Yeah,
But,
I'm sure.
at what point am I overstepping going up to the wound nurse and
Mhm.
saying, "Hey, did you do this? Did
Mhm.
a nurse on night shift do this? How can we improve?" Right? There's a very fine
Mhm.
line, but as a clinician and ethically, like I have to
Mhm.
say something because I
Mhm.
am an expert in wound care, even though I'm not practicing. It still comes down to what's right for the patient.
Yeah,
I think
absolutely.
sometime, yeah, when I was working in home health, one of the biggest
Mhm.
challenges I had was I was called in as a consultant like you do, right?
Mhm.
And you go in there and do your assessment and with the experience you have, you make these recommendations. But then the patient's like, "Well, my doctor told me that I shouldn't do that. I should do this instead." So
Mhm.
now we have a patient that's in between and needs to make a decision about which direction, they think they should go when they have no clue because they were never trained on wound care, right? But, you could see that provider that may have said something that didn't understand maybe a part of what was going on.
Mhm.
And that just puts like a wrench in the whole treatment, right? Because now we have to slow things down so everybody understands, and now a big decision has to be made in which direction we go.
Mhm.
Do you run into that? Have
But
you
that
seen
I
that?
yeah.
Absolutely.
Yeah.
We always say interdisciplinary team or
Mhm.
collaboration, but are we actually doing it? Do we have time to do it?
Yeah.
Do I
Mhm.
have time to call the physician that ordered the wrong antibiotics based on the PCR? That's going to be a 20-minute conversation with that physician. Do I really want to get yelled at today?
Right.
Sure. I'm advocating for the patient, right? So there's all of these factors that play into true collaboration. And we have to be confident in our skills and have the ability to call our
Mhm.
colleagues and other specialties and really come up with a plan for the patient
Mhm.
and the family and the caregiver versus, I'm so busy, I'll call tomorrow. Or I hear this one all the time. They didn't answer. They're not calling me back. I've tried calling them 3 days in a row. There's ways to get them. You better get their nurse manager, their nurse, their LPN, their assistant.
Mhm.
We have to be persistent in those cases.
I think what's so frustrating though is that I felt so when I was doing consulting in home health, and again, because let's lay it all out here. Wound care is not a specialty.
Mhm.
So the one thing that I really noticed was my husband has cancer, and oncology is very specific, right? So when we went in and when he got his cancer staged, and we went in and the oncologist pulled up a couple of these guidelines, right, and said these are our options. And he said, and they were all these flow sheets. And he said, if I go off of these, it's considered malpractice. And I thought, oh my goodness,
Wow.
wouldn't that be something that if we were able to say, you've been doing Dakins for 6 months and the wound hasn't made any progress, and you keep putting them on the wrong antibiotic and you haven't done vascular studies, and we keep asking that question, why is that not considered malpractice? And
Because there's
where
no
did the
standard.
education piece go for that? Yeah, because there's
Yeah.
no standard. But
There's
then,
no standard for
Right.
accountability.
yeah,
Yeah.
yep. And then you get yelled at, right? Because they're like, well, this is what I'm doing.
Mhm.
Right.
And you're like,
Hmm. I
and
think
then
that's
you're,
where the frustration is for
mm-hmm,
most of us, right, in wound care. So,
yeah,
but that goes back. We talked about this, Gen 2, about the
mm-hmm,
education that
mm-hmm,
is provided for nursing, for, providers, for doctors,
mm-hmm,
for NPs. I mean, just anybody in healthcare, really, and how limited that is. So, I mean, as a nurse practitioner that,
mm-hmm.
went through the whole program, I'm really curious. What kind of education in wound care did you get?
I've been a nurse practitioner for 8 years, and I was thinking, when did I learn wound care?
Mm-hmm.
Yeah.
What came to my mind, I believe it was one chapter in one class and maybe a few questions on the exam. They're focused on pharmacology, right?
Mm-hmm.
Diagnoses. How do we get to the
Mm-hmm.
diagnosis? What are the interventions for the diagnoses? But wounds, stage 1, 2, 3, 4, unstageable, those are the
Mm-hmm.
main ones that they go over. Your venous leg ulcers, your diabetic foot ulcers, they may have touched on it, but they're not going into great detail. So
Mm-hmm.
my education was actually after I
Mm-hmm.
graduated. I chose to go to a specific organization to get training
Mm-hmm.
by myself because I want to have more knowledge and be an expert in
Mm-hmm.
it. And I don't feel like I had sufficient education on wounds, at least at the time when I went to nurse practitioner school. Now it can be different, but I'm assuming, right? We don't want to assume, but I'm assuming it's not that way because we
Mm-hmm.
see brand new clinicians or nurses that cannot even stage a wound. And that's a little
Mm-hmm.
scary to me.
Mm-hmm.
We at least need to
Mm-hmm.
assess and stage, right? And
Mm-hmm.
then we go to our clinicians or experts to get the intervention. Let's do it that way for now until we get
Mm-hmm.
something standardized. But I think you're correct. I believe it during initial training, medical school, NP school, PA school, nursing school, there
Mm-hmm.
should be curriculum. a whole semester, in my opinion, right, on one class for a
Mhm.
semester on wound care. And
Mhm.
that's not just evaluating staging, it's interventions and education. How do
Mhm.
we address it with the patient's family? How do we address it with other clinicians
Mhm.
and physicians too? But
Mhm.
also clinical rotations. I don't remember seeing any wounds during my clinical rotation. I
Wow.
saw the procedures, so peg tube,
Mhm.
all of that, trach,
Mhm.
suctioning. Those were the
Mhm.
big ones we had on our checklist. But did we have a wound vac dressing change?
Mhm.
Wow.
I don't
Yeah.
believe so.
No,
So
we
even
didn't.
during that clinical rotation,
Mhm.
adding some exposure to complex wounds and the procedures. If the wound care nurse is coming on at 8 p.m. and rounding, hopefully that faculty can say, hey, can my nursing students follow you for the day?
Yeah.
What great exposure is that?
Yeah.
Yeah, right. We actually had, so I mean, I always sing the praises of my original wound care center that we opened, but we did have the nurses in nursing school round. They would each come
Amazing.
for a day.
Wow.
That's amazing.
That's
During their, I
awesome.
think it was like their second, like their med surge second rotation,
Mhm.
and they would come to the clinic for a day. And you know what? Some of those nurses I am still friends with after like 13, 14 years because they literally fell in love with wounds when they were there with us. And they were like, this is my life's goal. And they loved it because they loved the critical thinking behind it. They loved the fact that it had almost nothing to do with the dressings. It was
Right.
everything else around it.
Mhm.
And Therese and I were saying we're on this Facebook group, and it's always amazing to me that the first thing everybody asks is, well, what do I put on this?
Yes. All the time.
All the
First
time.
question, all the
Here's a
time.
picture. What do I do with this? And you're like,
Yeah.
uh
I think I'm part of that same group, and I see it constantly as
Yes.
well. While they have uncontrolled diabetes, the blood sugars are in the 400s.
Yes, right.
And the
It's like,
frustrating thing
yeah.
is like everybody's giving advice on what they should put on the wound. And it's
Mhm.
like, you don't even know how much it's draining. No
Mhm.
questions. It's just all of a sudden, try this, try that.
Yeah, it's like, oh, hey, I mean, we're looking at this wound, and I look at it, I'm like, oh, we have a pibbly, we have rolled edges. How long has this been? What I mean, obviously, we have some friction and shearing problems. Where are we at with bioburden? Like, what's going on with this patient? And they're like, go ahead and use Silvadene.
I'm like, wait, what?
And I'm like, no, that's
Yeah.
that's terrible. I sound really, very like, I don't know, like snobby, but
No, but that's what has to go into it. You have to know those things, right?
yeah, it's like it's crazy. So, so I think we've established that there is, I mean, I can tell you, it's been how many years since I've been in nursing, like nursing school. And I don't know about you, Alicia, but like the one thing we had was the sterile wet to dry
Mhm.
dressing that we had to do for our competencies,
I remember
and I
that.
laugh now because what wound is sterile?
Right.
Mhm.
And if they're, and listen, nursing schools, if you're still doing that, stop it.
Yeah. Please rethink
Mhm.
that.
That is, and like,
Evaluate your curriculum
mhm,
and standards. That
mhm.
is not best practice.
No, that is not.
It's
And
not.
I'm in school right now, and so we had a great opportunity. We had this project, and they asked us to make sure we included evidence based uh, research on BID dressing changes.
What?
Mm,
And
BID.
and I said, I can't,
Mm,
because that doesn't exist.
mhm.
And I would love to know where your previous students have been pulling the evidence
Yeah.
before me for a
Wow.
BID, because maybe Dakin's for 2 weeks BID. I don't know. I don't know. But I mean, so we fundamentally have a school problem across the board,
Mhm.
but it's not pulmonology. It's not oncology. It's not cardiology. There is no wound science.
Right. I think there is now. I think we see more of that coming out in the conferences that we're
Hmm.
seeing the science behind, what we're doing, what we're using. which is very encouraging. But we haven't seen that bridge, at least I haven't yet, it to the
Mm-hmm.
field, right? To what people are actually doing at the bedside, or even the education that makes it understandable to somebody that's just starting in wound care.
Yeah, and that goes to the so we Therese and I were talking about there is so much education out there. I mean, there is
Yeah,
webinars, there is free stuff. If you
mhm,
want it,
it's there.
it's there. And so the question is we were like, you know, we were I was in the cereal aisle not that long ago and we were laughing about how many boxes of like how many kinds of Cheerios there are. There's like I don't know,
Like, when did this
700 kinds of
happen?
like why do we have 700 kinds of Cheerios? And so the question I have for you Alicia is do we have too much? Like is it not specified? Like is it overwhelming? And what stops clinicians at all levels from saying I want to educate myself? Is it only up to their employer to educate them or should we expect more? I don't know. I don't have an answer.
I believe as a clinician, especially in the primary field, if you're a primary
Mhm.
care provider, you should be an expert in wounds. And I think
Mhm.
that's some self guiding education. But with time, I mean, there's a
Mhm.
time constraint, let's be honest,
Mhm.
on CEUs. When can I listen to a podcast? When can I go to a class?
Mhm.
I love to do in
Mhm.
person classes, but who can get off a whole day,
Yep.
and take off
Mhm.
PTO and be away from their family and not be home for multiple hours? It is so hard, especially if you're seeing as a nurse practitioner 20, 30 patients a day. That priority list of more education, that's the last on the list,
Yeah,
I'll be
I can
honest,
see
right?
that. Mhm.
Um, so time constraint, I think, is a huge one, right? For seeking additional education. But I do think as clinicians, we are responsible for being the best we can. And that's learning. We are
Mhm.
always learning and we have to keep learning. But to your point, wound care products and options and techniques are evolving so quickly that I don't even know all that's out there, to be honest.
Mhm.
And the
Right.
reps calling, our product's the best. Here's the evidence, here's the white papers. But there's no one comparing these products to each other.
Mhm.
What I would love as a new nurse or
Mhm.
clinician, show me show me a graph of different products, by exudate level if you want, right? And show me the evidence. What is premier? What is not? But a lot of our choices are based on what's covered. So
I know.
insurance, we
Yep.
have to talk about it,
Mhm.
right?
Yeah, yeah.
Especially in at least in the home setting,
Mhm.
we're getting the generic products. We can't get some of these amazing technologies for these patients. They're ridiculously expensive. In
Mhm.
post acute, it's a little different. In the skilled nursing facility, hospital setting, you have what you have, and it's great because they typically have a bunch. And you just
Mhm.
scan it to the patient's chart, right?
Mhm.
Mhm.
Even though we're billing the patient for that, we can grab whatever we want. But I believe time constraint is number one. Number two, there's too many products out there and there's no evidence comparing each one of them.
Mhm.
And number three is insurance. They're
Mm.
tying our hands here on what
Mhm.
we can choose for our patients and
Mhm.
how often we can utilize products.
Right.
Yeah, absolutely. I mean, yeah,
It's in
absolutely.
it's interesting how so many times it comes back to the reimbursement piece.
Hmm.
It really does. I mean, you get all excited about something and then you realize half your
Mhm.
patients won't qualify for it.
Correct.
And it's
And then
it's
what do you do?
frustrating.
What do
Right.
you do?
You have
That's the
Mhm.
yeah,
only product that you believe will work for this wound.
Mhm.
Now what do we
right?
do? Who do we go to for guidance? You
Yep.
know,
Yeah.
who's calling us and telling us that the product is not covered?
Mhm.
When do we have time to call orders? But I think case management, that is key,
Mhm.
especially in wound care. There's
Mhm.
a
Mhm.
lot of things that get delayed
Mhm.
or brushed off because the clinician or nurse has so many things to do
Mhm.
that calling to make an appointment at the local wound care clinic or calling the home health to substitute, again, last on the list, unfortunately,
Right.
right?
Yeah. Or
Yeah.
calling the payer and working with them
Yes.
directly and saying, we have this, we have that. Can we do a carve out? Can we do this? Can we do that? You guys don't have time for that. You
No.
really don't.
So wouldn't it be cool, if you had somebody to help with that to allow the field
Mhm.
staff to concentrate on the education they need that's pertinent to what they're actually doing at the bedside with that patient, right? Understanding, the dressings, understanding the assessments and what they need to do, what are the key things for a venous leg ulcer, right? Instead of taking all of that time to do what you just said, right? Because I think with the education, like you said, there's so much that's going on ancillary to what they're actually doing at the bedside. That it's an overwhelming mode, is what it is for a lot of these people out there.
It is, and you have to know your local community too.
Right.
You
Oh,
can
Yeah.
have a
yes.
case manager that's virtual. That's
Mm-hmm.
great, right? There's some
Mm-hmm.
help there, but they're
Mm-hmm.
not going to know the community and the
Mm-hmm.
resources for that community.
Hmm.
So a local case manager or regional case manager specifically for wound care would be a game changer. And healthcare organizations, they've done a good job at getting case managers or clinical directors or social workers, right? But it's a generalized
Yes.
role. It's not specific to
Right.
wound care.
Well, you're singing you're strumming my song here, Alicia. You know that, right? Like, because that's been our passion for, I mean, since we first met each other a couple of years ago
Mhm.
we were all excited about having you out there with the patient,
Hmm.
being the nurse practitioner, and then handing it off to us to say, We'll deal with the insurance stuff. We'll deal with if you're running into a roadblock, we got you. We just want you to be with your patient. We want you to educate. We want you to get on to your next patient. Like, we will do all of those case management pieces underneath you. And yes, it's very true. I mean, you can have virtual case managers, but you're 100% correct. I'm a big advocate that every post-acute space needs to have case managers involved that are localized, that case manage their specific providers, that know what's going on with that patient and know what's going on in the community. And yes, does that mean that case manager, they can take care of a lot of patients if they have the right tools and the right technology,
Right.
and they can, and anymore it's getting better and better with AI. But yeah, you're absolutely right. And even in the acute space, because what I'm seeing is that the patients are being discharged from the hospital, and that's a mess.
I see it every day. Unfortunately, I did a small stent in the skilled nursing space, and I actually got out of it because I thought it wasn't where I thought it should be.
Mhm.
I'm back in it now, but it's better. I'll say it's better, but we still have the same issues across all healthcare organizations, right?
Mhm.
Rural is a prime example. They're
Hmm.
at this sophisticated rehab. Nurses 24/7. Wound is improving. They
Hmm.
live 2 hours away. They live with their
Mhm.
spouse on a ranch. They're 90
Mhm.
years old. They're going to have home health and maybe one CNA. Wouldn't it be amazing if that wound care nurse educated that patient family so they were comfortable on what could happen with the wound when they're at home versus giving them maybe extra supplies and a printout and saying, if this happens, do this. If you get a fever, go to the hospital. Your home health nurse will be out there within 24 to 48 hours. Pushing it on the home health agency. And then does the home health agency have enough time to educate the family on the wound, right? So we see it. I see it. Unfortunately, those wounds regress when they're back out in the community and they end up right back in that ER.
They do, because there's
Hmm.
no, and I'll tell you, with the home health situation, is that, what the problem is? It goes back to education,
I was
is
just going to
that
say that.
n- n-
Yeah.
those
Hmm.
nurses in home health, unfortunately, and I'm going to be real blunt, they have not been trained.
But they
So
want it. They
they,
want the
I
training.
know,
Yeah,
I
they
know,
want
They
the
do.
they
training.
want it.
I educate home health locally and they're like, "Thank you. Thank you
Right.
so much. I can
Mm-hmm.
put this into my practice today, and it will
Mm-hmm.
benefit a patient
Yep.
and a family today.
Yes.
Turnover
I
is
mean,
another huge issue, I think, in
mm-hmm.
healthcare, specifically in home health.
Mm-hmm.
A lot of agency, a lot of PRN. It's so difficult to provide education when you're not full time, right? And it's when
Mm-hmm.
it's not consistent.
I think a
Yeah.
lot of agencies don't want to invest. I've been told that before because they
Mm-hmm.
said, these people come and go, and I don't want to spend all this money
Mhm.
if they're going to go take this
It's true.
education to another. But, going back to what we started with,
Mm-hmm.
and it's very interesting, is that, and it's true because I've seen this, all these nurses want this and they're thankful for
They
it
do.
and they utilize it. It's not just like they sit through it, they actually utilize what they're being
Mm-hmm.
taught. There's so much of it available, so much
Mhm.
of it. And it's a lot of it is free,
It
that they can
is.
do. So I think that goes back to what your initial question was, Jen. Is like, what's our point here, right? But why aren't people engaging with this free education? And
Mhm.
I think that's one of the things that we talk to our audience is maybe think about that. If you're in wound care, if you're in healthcare, not just wound care, but you're taking care of patients, you're taking care of patients with diagnoses that more than likely can end or have a wound, right? So
Mhm.
it's important for everybody to understand how to prevent that, understanding that disease process where that patient may end up with a wound. So it's that education that, needs to really be utilized, right?
But I think to your point, though, Therese, and I think to Alicia's point, is that they don't have time. So
Yeah,
if the
right.
agencies, the facilities, if all of them said, you know what,
Mhm.
we're going to actively train our nurses in wounds when they're onboarded, we're going to actively continue
Hmm.
to train them, regardless of if they might go, because it benefits us as an agency,
Hmm.
it benefits us as a facility, and it stops us hemorrhaging cash on the back end because that's what
Mhm.
happens with the wound care patients. So my question is I'm going to put this out there. I'm going to be very real. Facilities, home healths, why are you not actively training your staff as a part of their actual employment? I'm going to be real blunt because your patients aren't doing well, just like Alicia
Mhm.
said. They're not
Hmm.
doing okay, and you're actually losing money. So, and we see
Yeah.
it every single day, right? And these patients go back to the hospital, and the closer we get to value-based care, the more this is going to be super painful. And so
Mhm.
I'm going to implore the employers right now out here to educate your staff, regardless of if they're PRN,
Hmm.
regardless on if you think they might leave, because it is the right thing to do. And your outcomes will benefit regardless. And I will say that in our previous lifetime, we educated home healths. And do you know, Alicia, that they had a 30% less turnover when
Hmm.
the agency said, I'm going to invest in education for you.
I believe that.
Yep. Yeah. They have a tangible support, right?
Mm-hmm.
That a lot of
Mm-hmm.
them aren't getting.
Mhm.
Yeah. Yeah. I don't think we've ever met a nurse that says, hey, I love walking into a house and having nobody to talk to and having no idea what to do about this wound.
Yeah.
Right.
Like, I
Right.
don't even know what I'm looking at.
Yeah.
It's,
I think
and
we
I can't
talk
educate.
about time. Time is a huge constraint, but I think
Mm-hmm.
in the eyes, if I had to think of another reason as to why they're not doing that, is where do they start? Where do they go? Like we said, there's so much
Mm-hmm.
information out there. Who's
Mm-hmm.
going to help guide them with that curriculum? Who's going to help guide them in that onboarding with the best practice? There's
Mm-hmm.
so many things out there. You can Google, you can AI, but they need a true wound care expert in the field to help guide them.
And that's where that mentorship comes in, Therese.
I
100%.
would say
That
we
was the
just
next thing
talked
we were
about
like,
that. She's saying it. She's saying it.
and it's like, but it's the right mentor because, like, what we don't want is somebody
Correct.
who really, because I have said, and maybe you'll agree with me, Alicia, that wound care is like the biggest Dunning Kruger effect. If you kind of
Mhm.
know about wounds and you kind of know about dressings, you think you know everything.
We've always done it this way. Or
That's another
all
one.
wounds
Yeah.
need antibiotics. That one is, oh.
Oh, oh, let's not. Oh, yeah. No,
Yeah.
like everything. Yeah, no. Or we need to change this daily. Absolutely has to
Ugh,
happen.
Hmm.
yeah.
So,
Yeah.
I mean, how do we get mentors out there like you? How do we get mentors into these facilities, into all the post-acute spaces and even the acute space? How do we do this? How do we and make sure that those mentors know the standard of care?
Mhm.
Yeah, that
Yeah.
goes
What are
back to
your
that Facebook group, right? Where everybody thinks they're a mentor and all this wrong information. It's like, wait a
Mm-hmm.
minute.
Mm-hmm.
Yeah,
So it has
I
to
would say
be.
to
Mhm.
first start, definitely if you're listening, your local experts, right?
Mhm.
You can go to organizations like AANP and find different things, CEUs and such and things like that. But I think reaching out to a local, reputable
Mm-hmm.
wound care expert by asking around. Everyone
Mm-hmm.
knows everyone, right? In healthcare.
Mm-hmm.
So see who's rounding in the home setting, in the skilled space,
Mm-hmm.
and go to them. They have experience in interventions and the bigger groups I would say is okay. There's smaller groups out there, smaller organizations that are trying to do wound care too, individual nurse practitioners or PA, which is fine. But I would say those larger organizations that are rounding either in the home setting or facility or hospital setting, or even in the clinics too, call your local wound care clinic. Hey, who's your doc? Who's your
Mhm.
medical director? Research them. We have an amazing platform, LinkedIn. You could
Right.
find
Right.
someone in 2 minutes, right?
Right.
That is
Oh.
reputable. Look at their connections. Look at
Mm-hmm.
what they're involved in. That's
Mm-hmm.
where I would
That's huge.
start.
That's true. I agree.
Yeah. No, that's really, I will say this. So on a side note, PAWSIC, because this is a PAWSIC
Mhm.
podcast. So I will put a little shout out for PAWSIC and for Therese because they are putting together a consulting situation. And what they do want to have is basically a list of reputable mentors, reputable consultants. So you can get right on the PAWSIC website and say, oh, who can I call? Who's available? And I'm super excited about that because it falls right into what we're talking about today because we really just don't have a true north for that right now, I don't think.
Mhm.
That's incredible. And once that's live, we should scream it to the
Yep.
rooftops because that's such a
Mm-hmm.
great resource for
Mm-hmm.
all organizations and home health, specifically home health too.
I know
But
the home health. Mm-hmm.
it's the master guide, as I say. We're always looking
Mm-hmm.
for a master guide.
Mm-hmm.
Right.
And
Yeah,
that could, as a resource, that could be our master guide.
and I love it. And
Yeah.
there's some other things that POSIC is doing too that they're really just trying to organize and have a central place to go for all these post-acute
Mhm.
spaces to say this is what we really have to do. And again, that's why I just love being a part of POSIC because of the paradigm shifts that they're trying to accomplish. And we know it's like it's we're basically trying to turn a giant ship very slowly
Mhm.
because of all the behavior that we have to change. But I'm really hopeful that the future will bring mentors, education, um, and it has to. I mean, let's be fair, guys. Like
Yeah,
it
no
has
kidding.
to change.
Yeah.
Mhm.
Yeah.
We can't keep doing the status quo.
Mhm.
We can't keep being like, hey, we're not going to educate our staff. We're not going to try to all adhere to the same standard of care. And and that's including surgeons. That's including PCPs. We have
Yeah.
to because we're failing. It's what? Almost it could be up to $95 billion
Yeah, it's
of a
crazy
problem
financially. Mhm.
and outcomes worse than cancer.
Scary.
Yeah.
And we have a population, this huge
Mhm.
population that's been entering, this whole
Mhm.
realm. So we have
Mhm.
to get it together. We really
Yeah.
do.
And the only way we're going to do that is if we start with good mentorship and we start with a true north education. And again, it goes right back to it's got to be in the nursing schools.
Mhm.
Nurse practitioners need a whole class. Um, it needs to be in basic nursing school,
Mhm.
and and that's where it has to begin. I think. Would you agree?
I would agree. And I would even say in your CNA school.
Mhm.
I was
Mm,
18 taking the CNA course that was offered through my high school.
Mhm.
And that's basic,
Mhm.
looking at urine, emptying a Foley, etc. Why
Mhm.
not? Looking at a wound, assisting the nurse in the dressing change. What is Coban? What is a Mepilex? Very basic
Mhm.
knowledge, but I think they
mhm,
would grab onto it and then they have more exposure so that they're
Yes.
comfortable when they enter that role.
mhm,
And if you
Mhm.
don't have exposure to wounds, how do you know that someone who's really great at that specialty, I'm going to call it specialty, even though it's not,
Mhm.
we don't even know they're out there. If I wasn't
Mhm.
exposed to wounds in my early days as a nurse at a hospital setting, I probably wouldn't have gone into wound care, to be
Mhm.
honest. So the more exposure we have to
mhm.
entry level healthcare positions or CNAs, LPNs, RNs, NPs, the better we'll become.
Mhm.
I think, Jen, you
Absolutely.
said it. I mean, when you have a program that exposes
Mhm.
new grads or people in school, it opens up a whole new area that they never
Does.
would have known. We talked, I know, yesterday a little bit. So I'm an LPN, right? And I'm older. So going back way to the days when I started, all of the education back then really came from the reps. Because if you remember,
Yes.
they would have like tons of samples. They would just stock
Mhm.
you up with samples, and then they would spend time helping you understand what the dressing did and how it worked. So it wasn't like the best, but at least it was a
Mhm.
hands-on experience where you had somebody there that was a mentor for obviously the product, but at least you were getting an education of this dressing and how it worked.
Mhm.
And that's how I got started really in wound care, because I remember going into a patient's home and they had a calcium algae. Nobody told me what this was. And they had us cut it up into these little tiny pieces for all these little wounds. And it was almost like a puzzle. I was there for like an hour and a half just putting these calcium. I had no idea what it was. Right. So then I started learning, and it's just like then you started seeing the result of
Mhm.
what the products were doing. So then I took the deeper dive into what was behind that. Why was that
Ah.
working, or why wasn't it working for somebody
Mm.
else? There was that curiosity. And that's how I
Mhm.
got my start back then, because I had almost like hands-on in a mentorship, so to speak,
Mhm.
that
Mhm.
isn't there in that way today. So that's why I think mentorship and being, having somebody to talk to ask questions, to give feedback, that is so critical with the education piece. So I'm totally on board with the mentorship
Mhm.
of what
Yeah.
you're
I mean, I
saying.
had the same
Mhm.
thing. I mean, I'm going to give a shout out to a huge rep mentor, and he is no longer with us. And his name was
Oh.
Ted Purdy. And I bet that if we have some listeners listening in, I bet you they will go, Ted. He was original cystogenics way back in the day, yeah, Prisma, Probran, all that kind of stuff. And I mean, I think half the world knew him, but what an amazing man he was, and what an amazing mentor. And you could call him with any science question. And if he didn't know, he would find somebody for you.
Wow.
And you could just always lean on Ted. And like I said, he's no longer with us. So that's why I feel like I can do that. But yeah, we don't necessarily have those types of reps, or maybe we do. Alicia, what do you think?
We do. I do. In my experience, we do.
Mm-hmm.
Mm.
Being part of a larger wound care organization, we had
Mm-hmm.
reps locally, regionally,
Mm-hmm.
nationally, with some of the larger organizations out there, and they collaborated with us. They invited us to free events. There was one with the cadaver lab, right, with the
Oh,
Oh,
cool.
pristine
wow.
surgeon, and all of our nurse
Mm-hmm.
practitioners were able to attend for free. Um,
Mm.
so I think there is opportunity
Mm-hmm.
for wound care organizations to reach out to these reps because the reps want us to not only partner with them,
Mm-hmm.
but they provide education and they
Mm-hmm.
can be a mentor to us. So they're out there. It's just a matter of who,
Mm-hmm.
where, and then
Mhm.
contacting them, right? Takes
Mm-hmm.
one phone call, one message on LinkedIn, and you have a partner for life.
Oh, yeah. Yeah,
That is true.
absolutely. That is very true.
Mhm.
I mean, I have some reps that have become personal friends of mine over the past
Mhm.
20 years. And even if they jump ship to a different company, they are still like, hey, Jen, you want to know about this? And so, I mean, like these, I mean, because we're such a small little community in wounds, but
Yeah.
you're absolutely right. I mean, so what I'm hearing is we literally have millions of ways
Mhm.
for us to try to find a mentor, for us to try to find education.
Mhm.
But it seems to ultimately come down to desire, time, ability,
And
which then
Taking that
comes.
expertise.
first step,
Mhm.
taking
Yeah.
Hmm.
that first step, doing that outreach. Just
Hmm.
Right.
take the first step. Do it.
Right.
What's
Yeah,
holding you back?
right. I mean, go randomly call your home healthcare agency and say, "Hey, can I come in for an hour and teach your nurses?" I mean, really, seriously,
Yeah.
I do that.
Yeah.
Like, don't pay me anything because I really just want your nurses out there to take care of patients. Like, that's just where I'm at,
Mhm.
you know, because they
Yeah.
love it. They absolutely love it.
And
Uh,
wouldn't it be an amazing thing if anyone in the wound care space, if they're not certified, that their
mm-hmm.
employer would pay for their wound care certification? I was at a previous organization, they did do that, and
Mm-hmm.
it is incredible. You have that for life. That
Mm-hmm.
Yes.
knowledge is so tangible,
Mm-hmm.
not only to the patient, but to the outcomes.
Mm-hmm.
Call
Yeah.
to action to all employers out there.
Yes.
If you do wound care and your clinicians and nurses are not wound care certified, they should be. Please offer it to them. They want it. I have a feeling
Mhm.
it'll be mandatory in the upcoming years, right?
Mm-hmm.
With the value-based model,
Mm-hmm.
but offer it to them. Give them the chance to learn and get certified and be experts in it. And
Mhm.
I'll even take it a step further. Primary care.
Yes.
Primary care docs and Ps,
Mhm.
PAs, please take a course. But a wound
Mhm.
care certification on top of that would be absolutely incredible. And you would be
Mhm.
doing your patient population justice.
Yes.
That's true.
Amen. And actually, we had it on our list. We were like, Alicia, what do you think about certification programs? You just answered
Mhm.
our question. That was actually on our list. So, like, I'm really happy that we got into that because I completely and totally agree with you. I completely
Mhm.
and totally agree with you. And again, I think we're looking at, employers being so afraid to spend that money or,
Mhm.
I'm going to lose I'm going to lose that clinician.
Mhm.
But I'm going to say this as a whole. We are loyal to employers that invest in us.
Mhm.
And so I'm just going to put that little tidbit,
I
out
think
there.
And
that's
there's
true.
things that the legal department can put in contracts.
Mhm.
Like, let's be
Mhm.
honest, right? There's
Mhm.
a lot of healthcare organizations out there that, if we give you this, you have to stay with us 1, 2, 3 years, etc.
Mhm.
Put that in your clause.
Right.
Talk to your legal team. Why not?
Mhm.
We'll offer you wound care certification, but you have to stay with us
Mhm.
for 1 year. I'm sure there's
Right.
ways around it. However, we're giving something to them.
Mhm.
It's professional and respectful to stay at minimum for
Right.
that return.
Mhm. Yeah, because I mean, you're wound care certified for life. I mean, at that point, as
Mhm.
long as you keep it up. I mean,
Right.
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 Yeah.
yeah, right, exactly. So no, so I'm happy to say I think I think you are all aligned with Therese and I as we were, thinking, gosh, wouldn't it be fantastic if because at least we know in the couple of national certifications that we have that training is uniform
Yes.
so that everybody would have the same
Mhm.
base knowledge
Mhm.
about wounds. And we're excited about the professional, case manager education as well that will be coming out, that everybody will be speaking the same language in that as well, which is different really from a wound care certification because now we're talking more regulations and payers and things like that. But yes, it would be great if we were all speaking
Mhm.
the same language.
Wouldn't it?
And not just clinicians and nurses. What about the
Mm.
other pieces of the puzzle? Dietitians, your
Oh,
nutritionists, social
mm-hmm,
workers, your
mm-hmm,
therapists. How many patients are on
Yeah.
therapy that have wounds?
mm-hmm,
Could you imagine a world where everyone has basic wound knowledge and we all talk the same language and they can call us, "Hey, I was with your patient Miss Smith
mm-hmm,
today. I see her wound is draining through the dressing.
mm-hmm.
It's purulent." Can you imagine a physical
Ooh.
therapist calling you And you getting that information, what it can do for that patient, incredible.
Or your CNA, even
Yeah.
your CNA, to say, hey, I don't know, I gave so and so a shower, and there was
Mhm.
some really a thick tan drainage coming from that dressing, and I just wanted to make sure that you knew that was important for you to know.
Amazing.
Think of the hospitalizations, right? That would be prevented.
Hmm.
The ER
Yeah.
visits. Yeah.
Yeah, I mean, it's like, how do we? We have all of this, right? How do we go out there? How do the three of us go out there and change the world? Because I feel like
Yes.
we have an entire army behind us that agree with us. But it's like, how do we change it? It's a huge paradigm shift, but how do we change it? And I think one of the biggest things is that wounds are a chronic wounds are a cutaneous manifestation of a disease process. We have to think about it as an expression of a disease process more than just a hole.
Mm-hmm.
And when you start thinking about it like that, then you realize it touches everything.
Hmm.
Everything.
Mm-hmm.
Hypertension, diabetes, obesity, autoimmune diseases. You have to address all of those things. So it becomes everybody's problem,
Absolutely.
everybody's
Yeah.
issue.
I ask myself, because I don't know. Do endocrinologists get training on diabetic foot ulcers?
Probably not.
I don't know.
That's
Do
a
they
good
send them
question.
to podiatry? Do they have a partner that collaborates them with them? You know, that standard of practice, specifically for those
Mm-hmm.
specialties,
Mm-hmm.
endocrinology, diabetic foot ulcers. You got your
Mm-hmm.
vascular surgeons, they deal with VLUs all
Mm-hmm.
the time, but
Mm-hmm.
every specialty should be trained on a minimum what affects their specific disease process that they're
Right.
educating their patients on every day.
Absolutely. I don't think they
Yeah, that
do.
makes sense.
I think if they get anything, it's super basic, but I don't
Mhm.
think that they do. Based on my experience and actually talking to one here recently,
Mhm.
I think it's very, very limited. Um,
I've seen too where, you send them to a specialist for something that's going on and there's a wound involved and the specialist will put it back to the nurse or to the home
mhm,
health agency or to the
Mhm.
facility
mhm,
because they think or they want them to take care of that part and this is where the silos come in, right?
Mhm.
Because we're not understanding the connection. And I think that goes the other way too is the nurses in the facility or the home health agency aren't really understanding that connection. So
Mhm.
it really is tying it all together, not just
Mhm.
with bringing the teams together, but the education and the overlap of where all that happens, because I think
mhm.
that's the disconnect in a lot of situations.
Mhm.
I think we could literally have about 4 more podcasts
We probably could.
just on this topic. And Alicia, we would love to keep going and keep talking. But I think that so what is the next podcast? How to break down the silos with better education? Is that the next podcast that we're going to do together?
Sounds like a good one.
It sounds like a
I
great
like
one.
it.
Well, Alicia, we are so happy that you joined us today. And I know we kind of went in 50 billion directions, but that's the whole point of this conversation.
That's right.
And I hope that we put some food for thought out there for our listeners. And maybe we were a little harsh, but
That's okay.
that's okay.
It's
We're
okay to
okay.
be direct and get to the
Mm-hmm.
point.
Yeah.
Mm-hmm.
When I do presentations, I have a lot of nurses that come after and say, "Hey, thank you for just getting to the point and
Mm-hmm.
not beating around the bush and putting in fluff." Right?
Right.
Yep.
It's time. We need to
Mm-hmm.
get to the root cause and
Yes.
really analyze it and fix it. And I think being direct is a good thing, specifically in wound care. And I just want to say thank you to you both because you guys are pioneers in the wound care industry and you guys are doing so many amazing, incredible things, not only for the current individuals who practice wound care, but for the future of wound care. So I wanted to say thank you guys.
Thank you.
Oh, Alicia, I'm going to
I
cry. Thank
know.
you so much. I know we've always been kind of champions for each other over the past couple of
Mhm.
years. So to have that support from you for us,
Hmm.
thank you. That means a
Yes.
lot.
Thank you. Yes.
Thank you. Thank you. All right. Well, Alicia, I'm so happy that you joined us on Healing by Design, and I'm sure we will speak again soon. Everybody, I hope you enjoyed this conversation. If you have any questions, comments, or even pleas of impassioned outrage, please let us know, and we will see everybody later. And that's a wrap on today's episode. Thank you so much for spending time with us. These conversations are why we do this, and we don't take it lightly that you chose to listen to us today. Before we head out, just a reminder, everything you heard today is meant to educate, not to replace the advice of your own healthcare provider. Please don't make medical decisions based on what you hear on this show. Your provider is the right person for that. Our guests share their own opinions and experiences, not the official positions of PAWSIC or anyone who supports this show. If you're dealing with a wound care emergency, please get to someone who can help you right away. And if today's episode was useful, subscribe and share it with someone in your corner of wound care. It helps us reach the people who need it the most.